We are going good.
Yeah, so it's just like 4 slides. Just it's more of discussion. I'm not going to show any videos. So I'm trying to convert surgical cases into medical retina cases. This is a 23-year-old gentleman who had presented to us with a history of blunt injury, and as you can see, there's a macular hole at 20/40 vision, a very small hole. And this was in 2019, and I had just started on, let's say, topical medical therapy. One way to look at it is just leave it and observe. But I thought, let me try to push it, or whether it's a placebo or a real effect, I don't know. And I will just come back to the ophthalmology retina publication in December, where they published a large series, not a very large series, but they did prescribe these what I had already done. And then lo and behold, this eye's macular hole closed, vision improved. So the debate here again, I would like to ask the panelists, how long would you wait, and is just observation good enough, or would you like to use some of these topical medications? Because as per the publication in ophthalmology retina, these eyes, if you treat them with NSAIDs, steroidal drugs, as well as brinzolamide, they use brinzolamide, the closure rates were 3 to 4 times than what is seen as spontaneous closure. So I'm just trying to see whether we should debate usage of these drops. This is another patient with an idiopathic macular hole. This is not post trauma, as you can see, an elderly lady about 60 years old. And when she presented to me, this OCT was done elsewhere a year ago, and she was told that she has to undergo surgery, and that's what I would have also advised if she had come to me with the same scan. But I thought I did not see a macular hole in clinical examination, and obviously I repeated the OCT scan and like looked carefully at all the scans. There's no macular hole, and the vision is also probably improved. We did not have the earlier visual acuity, but obviously the hole has closed. So in this case, she did not use any eye drops as such. So in the first case, I showed a case where we used some eye drops, and in the second case there were no eye drops which are prescribed, but you can say that they were non-surgically closed, whether it's spontaneous or not. Like in the first case, we used some drops, but my question is, at this point of time, are we looking at least in the small macular holes, are we looking to see if we can use some medical therapy and give it, let's say, about 4 to 6 weeks, maybe a little bit longer in traumatic macular holes, but should we give a trial in small macular holes and then look for surgery?
Very, very nice case. Raja, there were when I looked at this case of yours, it just definitely shows the recent discussion on topical drops. The first case was traumatic. There was no vitreoretinal traction. There was no vitreomacular traction, and it closed with the drops. In the second case, the vitreomacular traction was there in the OCT elsewhere, which possibly got released. So I had a question for Yoshi, that Yoshi, have you experienced this new concept of trying the topical drops? And if at all, then where do you particularly use them?
Yeah, great cases. And I think that when you treat a surgical condition medically, that's when you feel like an amazing surgeon and patients love you. They think you're God. And so I think this is definitely something we should strive towards. I think that the topical drops, I do use them for certain configurations where there's a lot of hydration of the macular hole, a lot of cystic spaces. I think, and smaller cystic spaces, I think those are cases where the drops work really well. However, in your two cases, personally, I wouldn't have done anything because the first case was a traumatic macular hole, and in traumatic macular hole, usually they're younger patients, but still relatively young here, hyaloids attached, small hole. The hole's going to spontaneously close more than half the time. And here, you asked a interesting point about when to intervene if the hole doesn't close. Usually for traumatic macular holes, I wait 2 or 3 months. But if there's any improvement on the OCT, I think following my OCT is really, really critical. If there's any improvement, I keep on watching. And the second case here, I think it was more the AP traction that was released by the PVD induction. And so the patient maybe went on a roller coaster ride or something, which can be a prescribed treatment as well.